All right, everyone, good evening. Welcome to UT Southwestern Science Cafe. For our regulars, welcome back. And for our new guests, we are so pleased that you've joined us this evening. My name is Jenny King, and I'm part of the public affairs team at UT Southwestern. And on behalf of my colleagues, Joya Lang and Charlandra Thompson, as well as our guest speaker, Dr. Namirah Jamshed, thank you so much for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into science topics. We also have fun while we learn. Our format is casual and interactive, and we encourage you to ask questions and engage with us during the program. This evening, we will be discussing the science of aging, dementia, and emerging geriatric medicine with Dr. Jamshed, and more on her in just a moment. So before we begin, we want to mention a few technical matters. We are recording tonight's program, and we are also live streaming it on UT Southwestern's Twitter page. We ask you to go ahead and mute your microphones during the presentation to help with everyone's audio clarity. And if you have a question in the chat and we call your name, please go ahead and unmute to ask your question. We encourage you to utilize the chat feature to list your questions for Dr. Jamshed, and we're very pleased that we had many questions submitted by you in advance as well. We will start the Q&A at the conclusion of her presentation. Joya will be facilitating Q&A, and we are also monitoring your questions that you submit during the presentation. Finally, just a reminder, while we cannot answer personal medical questions, we would love to hear from you with general questions about tonight's topic. And with that, I am so pleased to introduce our guest speaker. Dr. Namirah Jamshed is an associate professor in the departments of internal medicine and family and community medicine at UT Southwestern Medical Center here in Dallas. A specialist in geriatric medicine and dementia, she serves as medical director of the UT Southwestern Care of the Vulnerable Elderly, or COVE, home-based primary care program. Joya will put her bio link in the chat. Dr. Jamshed, thank you so much for joining us this evening. Welcome to Science Cafe. The virtual podium is yours.
Thank you very much. Thank you for that kind introduction. Welcome, everyone. Thank you for taking time out from your evening. I want to leave a lot of time for discussion and questions. And I've geared my slides towards hopefully everyone. This is not a scientific lecture, so hopefully everybody will be able to gather what they need to. So let's go ahead and just start and then get right into it. And I'm going to share my screen, and we're going to go into presentation mode. And here we go. Okay, so I don't have any conflicts to declare, but we will start with the participation from you all. Let's start with the first question. Do you have a loved one who has dementia?
Yes.
Okay. Okay, so almost half the people do. Okay, and okay, great. So it's almost 50-50. That's great. Hopefully this will help you. Let's go to the next question. Where do they live? People that you know have dementia, are they living at home? Are they living in a facility, which could be a group home, or are they living in a nursing home? Okay. Okay, excellent. I will tell you guys a little bit about myself later as I answer questions, but this is not uncommon. Majority of the people are living at home and probably have a caregiver who's taking care of them. And we will talk about that. And I have a question regarding that soon. So let's just start getting into the definition. So dementia is any disorder where you have a significant decline from a previous level of cognition. But most importantly, that decline should affect your occupation, your regular work, social functioning. It is an acquired syndrome. That means you get it. It's not something that you're necessarily born with. But dementia is a general term, and we're actually getting away from using it. We call it more neurodegenerative disorders. And there are different etiology, different reasons why somebody could get it. Alzheimer's is just one of them. People can get neurocognitive decline or dementia from tumors. They can get it from, the front part of the brain, the frontal lobe area degenerating. They can also get it from vascular disease. Somebody has heart disease, high blood pressure. It can cause little damage in the brain and can cause dementia from that. Parkinson's disease can cause dementia. And then there's a special type of dementia called Lewy body, which we can talk about. But just to understand that dementia is just an overall description of how the decline in cognition is affecting your daily quality of life. So there are different types. There's the neurodegenerative types where the brain cells are actually getting damaged. And as they're getting damaged, you are seeing the effects and consequences of that. So depending on which part of the brain is getting damaged and how much of it is getting damaged, you will see the consequence. So if you have Alzheimer's disease, if someone has Alzheimer's disease, it may start in one part of the brain, but as time goes by, that degeneration process is going to spread to the rest of the brain. And as it spreads to the rest of the brain, that's when you start seeing decline. Whereas the non-neurodegenerative, where it's actually something else that's causing it, is a little bit different. And the way I usually tell my patients and caregivers is the non-neurodegenerative type may stay the same or similar for a very long time. So for example, somebody having a stroke, if they have had a stroke in one part of the brain and they don't have stroke again, they may have that dementia for a long time. Depression, depending on how it's treated. So these are external causes that can cause dementia that potentially we could prevent, right? In the US, 1 in 9 people age over 65 and older have Alzheimer's disease, which is the most common form of dementia. But unfortunately, the older we get, the more the risk of having dementia. So 1/3 of people over the age of 85 will have Alzheimer's disease. So you can see in this pie chart that the majority of people who have Alzheimer's are 75 to 84 and then 85. But it's not that common under 65. And if someone gets Alzheimer's disease under 65, we typically call it early onset Alzheimer's disease. Now, as we get older, this number will keep going up. This is just one data set that we have. Now, between 2016 and 2025, which is just honestly just a couple of years ago, every state and region across the country is expected to see an increase. And we can look at Texas. Texas is right here. We have 34 to 41% people with Alzheimer's disease. And the dark ones, the dark purples, are where they have the highest number. But we are going to be the dark purple soon. And this dark purple may have to change to a different color. So the West and Southeast are expected to experience the largest increase in patients, in people with Alzheimer's. The lifetime risk. So if you're 65-year-old, as you can see, and I teach my learners as well, the risk is much higher in women. Some of it here in 85 and older has to do with the fact that the life expectancy is slightly longer. But this is the data from the big study Framingham that you may have heard about in different presentations as well, that women have a higher risk, but men also have a risk. So as we get older, if you've ever been to an assisted living facility or a nursing home or a memory unit, you will see that there are more women than there are men in those memory units. So that is one fact. As you can see, the purple are women, the yellow are men, and women have a higher risk at every age group. And the risk for men goes up as well. So we're going to jump right into the medication management, because that's going to be a question that everybody would like to know. What can we do about dementia? And as clinicians and physicians, when patients come to us, I think many times you are expecting that we have something that we can give you or your loved one to help. Unfortunately, we have tested about 244 medications for Alzheimer's, and none of the medications available today slow or stop the damage. The medications can temporarily improve symptoms because they increase neurotransmitters. We'll talk about that a little bit, but the effectiveness is variable between different people. So You could try it on me and it will have a very different effect than if you try on Jenny or try yourself. And there's no way to know that until you've actually taken it. And that's where the caregiver feedback becomes very important when we do decide to start these medications. Someone had asked a question about supplements. So I'm going to talk a little bit about a couple of new things in dementia. There is one study that has shows vitamin E to slow functional status, but only once the dementia has already been diagnosed. And so it's not something we can use to prevent, but it is something we may be able to use to delay. I put the points here because you have to understand when we do studies, we're doing these mental tests, and we're looking at points. And if you look at the point number, it's so small. But because vitamin E is not harmful, there's no harm in trying it in people who already have been diagnosed with dementia. So I've tried it on a couple of patients. I'm not sure it helps or not, but many of my people are already taking it, so you don't have to do more. I do want to point out that cognitive stimulation programs are very beneficial. So I was in fact recently reading a book on this, and one of the things that typically stays with memory is music. So music is something that if you know your mom liked classical music or jazz or whatever kind of music, play it again for them. They will remember it. And you will notice that in a lot of facilities, they play music. Sometimes when I go in, they're playing music that I'm thinking, I don't think my people know this. So think about what kind of music they like and play it for cognitive stimulation, because it's going to open up that chapter of music in the brain. All right, so there is a new drug in town. It is called Dukana, aducanumab, and you can see I don't even know how to pronounce it. It was recently approved by FDA. I can tell you there's a lot of controversy about the drug. We have a couple of hospitals in the country, most of the leading ones who have declined to use it. There is an associated risk, but the risk and the damage that happens with the drug can only be seen on an MRI. The number of people, the cases, you can see on the bottom here, the number of cases is only 170. Everybody was surprised when it was approved. So we actually suggest not using it routinely. I think there will need to be a to me, it's almost like having a discussion about chemotherapy. You're going to have to talk to your specialist and have a very lengthy conversation and figure out if this is the right drug for you. I can see a push for using this in younger people who have Alzheimer's disease. But again, we don't have enough data. And at least for myself, I have not recommended to anyone that I know. And I do take care of some younger people as well. So a lot of things that we still need to learn about it. The most common drug that we use are what we call cholinesterase inhibitors, and you may have heard about them: the Aricept, the galantamine, rivastigmine, Exelon patches. What they do is there's this neurotransmitter. They basically increase that, and we think that by increasing it, if we have more of them, we can delay the progression, because the damage in Alzheimer's is already being done. It actually doesn't work for all types of dementias, but it may work. The data is really not that great. Again, the differences are only in points. So the three types that you will see in the pharmacy or prescriptions are donepezil Aricept, which is once a day dosing, and also comes in disintegrating sublingual tablets. So it's very easy to give to someone who doesn't like taking pills. Razodine or galantamine, which is given twice a day, also comes in a once a day pill, and rivastigmine and Exelon, which comes in a patch and capsule as well. We've had some patients get rashes from the patch, so be careful if you do end up using it. People will tell you this one is better for Alzheimer's, this is better for Lewy body. They're pretty much all the same. They're all generic now, so whenever I see somebody went from twice a day to a drug that is now once a day, is because probably, you know, their drug has gone generic. The company is probably not making much money off it anymore. But I really don't think there's much difference in the different format. I decide with the family if we're going to use one of these. And if we do use one of these, we decide what's the easiest way to give it. If it's really hard to give it to them by mouth, then you may want to use the disintegrating tablet or the patch. Otherwise, you just use the pill. The case for this, well, there's a very small beneficial effect in function or cognition scores, but they really have not translated into consistent benefits in patient-oriented outcomes, such as patient-rated quality of life or reducing the chance of them going into a facility or nursing home. So as much as we're using it, we really are not seeing a lot of benefit. I will tell you, there was a time in UK, they were not allowed to use these drugs at all. So, you know, here where it depends on who you're going to see. I'm not adverse to using them. I decide with the family. And remember what I told you, everybody responds differently. So we could try it. If it doesn't work, the most common side effect are nausea and diarrhea. And these are dose related. So that's why we give them with food. People can get weight loss from it as well. So, you know, and then there's a risk of the heartbeat slowing down, bradycardia, and hypotension, low blood pressure. And that's pretty significant. So if a lot of our people have heart disease and they're already on drugs that slow down their heart rate, we have to be very, very careful. And some people will get vivid dreams with donepezil. So what I recommend is if you're going to start it, go very slowly. And if you're going to stop it, unless it's a dire emergency, do not stop these drugs abruptly. Because if they've done something in your brain and you stop it, and the brain's going to get confused. So once you've decided that you're going to use one of these drugs, give it a 6-month trial if that's what you're going to do. Have the doctor should be doing cognitive assessments at each visit. The caregiver is extremely important, or the people around you, to tell us if there is a change, improvement in sleep or other symptoms. Nobody knows how long they should be used for. They're using it even in people who are dying, and they're using it in people who are doing okay. But if you do want to stop it, it really needs to be stopped over 6 months. Okay. Go low, go slow, go slow, go low. Okay. Which means go low, slowly increase it. And if you're going to stop it, go down very, very slowly. Okay. And I'll quickly tell you about one case. I was a young physician in my first job, and I got called to the principal's office by my boss, the chief of geriatrics in DC. And he said, Namirah, you discharged this person and they're right back in the emergency room within 24 hours. I said, okay. He said, you stopped their Cept. I said, yes, I don't think it works. He's like, well, they're going through withdrawal because they came back and they were, you know, not doing well, very agitated. So if that happens, just reintroduce the drug, but in general, don't stop it abruptly at all. So I learned by my mistake. So this is a Choosing Wisely campaign from the American Geriatric Society. So we recommend to not prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse gastrointestinal effects. Basically, it means that if you're going to start it, you need a good follow-up with your doctor. So you should see them every couple of months and check. We can use it for Alzheimer's, vascular dementia. There's unfortunately no benefit in patients who have dementia and Down syndrome. And you know, they have the nausea and GI effects that we talked about. The second drug that's really common is memantine, which is called Namenda in the brand name. And it does something similar. The difference is it was thought to be protective of the damage that's going on, but it really doesn't stop the damage from happening. So it protects that damage when you start it, and you can see that it's increasing the transmitters here. The data, this is a graph that shows placebo. These are people who did not take it, and these are people who did take it. And their scores were, the decline was much less in memantine. The FAST score is what we use for referring dementia patients to hospice. And we can see that memantine was better in regards to not giving it. And then there's the same for other things. These are activities of daily living. What I use for memantine is, memantine, it has lesser side effects, but it has to be used in more advanced dementia. So if I do use it, it's because I don't want people to have, people who have heart problems or have a lot of stomach upset and things. This is a better drug for them if we're going to use any drug. In general, the same rule applies. Unfortunately, this drug has also not translated into a realistic difference in quality of life. We talked about vitamin E, and you basically take 1,000 units twice a day. So which medications don't work? Statins don't work yet, although there's a big push for them to be used. They may work in people with vascular dementia, but we're talking about Alzheimer's. So if somebody has vascular disease, heart disease, has had a stroke, definitely use statins. NSAIDs like ibuprofen, naproxen, Celebrex, they don't work. Ginkgo biloba or garlic or things like that, they don't work, unfortunately. Omega-3 fatty acids don't. I don't usually discourage people from taking vitamins unless I see that it's interacting with their medical medications. But please be very careful with what you take over the counter. Some of them do interact with your other pills. Okay, last poll question. Are you a caregiver of a person who has dementia? Not too many. Okay, that's good. Well, I'm going to talk about caregivers soon, but I want you all to know that at some point you will become a caregiver. 50% of the caregiving in the US, whether it's for dementia or otherwise, is done by a family member. And majority of those are women. So all the ladies, I'm sorry to tell you this, but at some point you may have to do that, or your daughter-in-law, your sister, somebody else might be doing that for you. So we're going to talk about another topic. And if I'm going too fast, please let me know. A lot of people struggle with managing dementia-related behavioral and psychological problems. So we're going to talk about that. I'm going to play a voicemail. This is a patient, very well-educated person who ended up with dementia, and he would keep calling his daughter. And this is a phone call he made in the middle of the night, and I hope you guys can hear it. But if you don't, if you can't, I'll read it for you, okay?
This is Jack, again isolated in my apartment on the floor. Don't know why this to you reason. No reason given. They'll keep me here all morning and probably let me go for lunch, hopefully. Bye.
And so this person was very close to me. I saw him decline very quickly. So what he said was, this is Jack, and I'm being isolated in my apartment on the floor. No reason given. They'll keep me here all morning and probably when you come for lunch, hopefully. Bye. It was heartbreaking. He was so scared. And I think sometimes we forget what the person is going through when they're having these issues. So the way we treat this is, I want every caregiver to know and every person that something can be done. It matters what's causing it. The disability that the people experience is not just from one thing. It's not usually just dementia. People with dementia do have residual strands. One of the lectures I attended, the way they described it, think of a book with chapters. And there's some chapters that are closed, but then there are others that are open. You just have to keep figuring out which one can be opened up and read, okay? Presume that the patient has feelings and needs. Something I teach my residents and students all the time. Talk to the person. Don't talk to the person who's next to them. Talk to the person and they will understand you. And understand that the patient and the family, they're a unit. They're not separate. Everyone is working together, okay? This is a busy slide. I will give a link for this to Jenny and Joya, but it's very helpful if you want to know what kind of treatment might be helpful. It's actually from the British Journal. And the reason I put it here is because This slide actually talks about what should you do if somebody with dementia, with Alzheimer's or non-Alzheimer's, is actually having a problem, and if they're behaving in a way that is difficult. And it guides you into what are the medication options, which we're going to talk about. So most important, we don't go right away to the medications. Extremely important, okay? Stimulate their brain. Use music therapy if you have to. We counsel the caregiver. Do not be confrontational. If the person is saying, I'm feeling cold, they're feeling cold. It doesn't matter if you're not feeling cold. You have to acknowledge what they're feeling. You can try to change or distract them. You can make sure they're sleeping okay. Sometimes they're in pain and they can't tell you, all right? Exercise, somebody sent a question about exercise. If they can, exercise 30 minutes per day is extremely helpful. And we saw this in the COVID pandemic related to mobility. We had people in facilities who would be walking around and doing things. And because of the pandemic, they had to stay in their room. And we went from people being able to feed themselves to not being able to feed themselves. It's extremely important that the mobility continues as much as possible, okay? I'm gonna skip this for now, Jenny, because I don't think we'll be able to finish in time. If we can get back to it, we will. So the main thing, keep a routine. I will tell you, I'm not a big fan of routine, but everyone will tell you routine is better. But it's not, think of it this way, it's not your routine, it's not my routine, it's the routine of the person. So if you have a spouse who used to wake up at, I don't know, 11 a.m. every morning, and now they have dementia, and suddenly you're trying to wake them up at 7 in the morning, you need to have breakfast, you need to go to the bathroom, they're not going to do well with that. So I usually recommend to family and caregivers, use a routine that they're used to, okay, so that they can feel like things are normal. Anticipate what their need might be, what is going to frustrate them. For example, many times it's personal care. It's personal care in facilities when people are aides are trying to change them and bathe them. My God, we're very private people. It may be a person who's never taken a shower in front of anyone else. Why would they let you touch them? So you have to be very careful that that's going to happen. And then you have to provide them comfort. If they're agitated or aggressive, we always try to make sure there's no underlying cause like infection, medication, pain, anxiety, not sleeping well, depression, hearing aids not available, or glasses not available. So first, we want to make sure that that's not happening. If it's pain, then you give them something for pain medication. And then, we always start with something simple like acetaminophen, Tylenol, extra strength. Okay, I'll slow down. So we always start with something simple like Tylenol extra strength. You can give it up to 3-4 times a day. Sometimes we use ibuprofen and naproxen, but we don't generally recommend that in people who are older because of the risk of kidney damage. Whatever we're going to do, we have to have a discussion with the doctor. I would recommend not taking over-the-counter pain medications without consulting with your physician. There is some uncertainty whether drugs like carbamazepine, Depakote, gabapentin, or light therapy might help. There is not very good data on light therapy. I know someone sent that question in as well. However, what we do know is that if you expose people to daylight in the morning and have them sleep when it's dark, it can actually improve their sleep disturbance. And if they're going to sleep better, then most likely they're going to have less behavior problems. So again, in the pandemic, people being isolated in the rooms caused a lot of problems because they couldn't get exposed to daylight. Our brain senses the daylight and as being more awake. And we do this in babies, right? When we want them to sleep, we make everything dark. But when we want them to wake up, we make it lighter. Do not use antihistamines. These are medications like Benadryl. It's in a lot of sleep medications over the counter. We also no longer use benzodiazepines, things like Ativan, Xanax for sleep. They really affect the gait. You can get dependent on them. And some people actually can get worse if they take it. Now, if you have tried all this and nothing else is working, only then, and only then, we use the drugs called antipsychotics. These drugs have very high risk. And we use them if patients have severe hallucinations, not even regular, paranoia, delusions, attacking people, being aggressive. And we always use them for the shortest period of time. There are other medications that have not shown a lot of benefit. You will hear about trazodone, Depakote, quetiapine, but we keep trying to use them and see if it might help. Again, please be very careful and discuss with your doctors. These are the three most common that we use in older people. Olanzapine is called Zyprexa. Risperidone is called Risperdal. Quetiapine is called Seroquel. Okay. If I ever start a person on this, I have to keep seeing that patient every month and try to taper it. Side effects, it's highly sedating. It can actually worsen memory and cognition. Can have side effects like a person with Parkinson's has. It can cause confusion. It can cause falls, lots of side effects. It also increases mortality. There's a high risk of stroke and heart disease or heart attacks and death if we use these drugs. So when we use them, we have to explain that to the caregivers, that there is a possibility of that happening as well. So let's say somebody has chronic agitation. This is typically what I would recommend. Start with Aricept, rivastigmine, donepezil, memantine. Go to an SSRI antidepressant like Celexa, citalopram, Lexapro, escitalopram. Then go to the atypical antipsychotic. Then maybe a benzodiazepine. So these are all things that the physician should be able to do. The other common thing is depression, and this needs to be treated as well. The most common one that we use is sertraline, which is called Zoloft, Celexa or Lexapro. I have not prescribed fluoxetine or paroxetine in the last, 15 years because they have a lot of side effects in older people. Psychotherapy helps a lot. Mirtazapine really does not help much. It does help with appetite stimulation. The thing to remember is that these drugs can cause weight gain as well, especially the atypical antipsychotics. There are other people who are not depressed, they just have a very flat affect. No matter what you say, they don't show emotions. Those are people who we can sometimes use antidepressant as well. You will see other things being recommended like Ritalin. So that's another symptom. You can have sleep disturbances. We are trying to do more behavior therapy for that, like sunlight and then sleep. We've been using melatonin with very mixed responses. And then people who have the special type of Lewy body dementia can have a very, very difficult sleep where they're actually acting out in their sleep and they don't know what's going on. And that can be very disturbing. So to conclude, the pharmacotherapy does not have a role in routine management of insomnia or other sleep-wake cycles. We do not recommend using zolpidem, Ambien, and these drugs because of the high risk and the risk of dependence. You can use melatonin, that's one. There's a different type of melatonin, Ramelteon, and then there's trazodone. Amongst these, I always use melatonin first. Let's see. Wandering is one that is worrisome to a lot of people. People are restless. We get calls a lot from facilities that the person is wandering all night. And I tell them, let them wander. At some point, they're going to get tired. We have not been able to find anything that might help with this other than improving their sleep-wake cycle. At some point, the wandering goes away. At other times, it continues until the person can not walk anymore. We have patients who have sexually inappropriate behavior, making comments. You just have to keep in mind that they are not saying that intentionally, and we provide support and antidepressants. What plans should caregiver make for the future? I think the three things you have to think about are living situation, decision, advance directive, living will, and driving. For me, driving is the hardest one to talk about. to take away somebody's keys is a really, really difficult conversation. But we must understand that dementia, Alzheimer's disease does get worse over time. At some point, it becomes a question of safety, not just for yourself, but also for other people. And so that is a hard decision that sometimes we have to make. These are the different living situations. You have assisted living facilities, many in Dallas. This is a group home, adult day center, I'm sorry. So you go there for 8 to 5, you have activities and you come back. This is actually at home, somebody having a caregiver at home, and this is a nursing home. I'm a house call doctor, so I don't like nursing homes. The focus is always on keeping the people active. So I think, how are we doing with time, Jenny?
Dr. Jamshed, we should close up soon and go to Q&A.
Okay.
So maybe 5 more minutes?
Okay. Yeah, it'll be less than 5 minutes.
Perfect.
Some of the tips for how you can make daily activities easier for patients with dementia, so for example, someone just said to me, I'm talking too fast. Talk slower. I'm not saying that anybody has dementia, but talking slower helps, and talking in short sentences, okay? So instead of saying, how are you today? What did you do yesterday? I would just say, how are you doing today? One question at a time, all right? Try to stick to a routine. Don't assume that older people can't hear you. Talk normal, and if they can't hear you, they will tell you. Avoid giving too many choices. Keep clothes that are really easy to wear. Try not to move them around too much from one place to the other. It really confuses them when they have advanced dementia. If they're not eating, give them small meals. I have a patient whose caregiver leaves fruit on the table, and the patient would, just walk and go and grab it because that's all she remembered. And she would eat fruit all day, and that's fine. If they say that they can't taste things, sometimes it's because they can't smell, and you can add spices and soy sauce and things to make that better. Sleeping, again, try to keep a schedule. Open the shades in the morning, let the light in. Don't let them nap for too long. Wake them up. If you need to, you can use medications. If you're having a really, really hard time, I would urge you to please somehow take a break. There are different resources in the city. A lot of people underutilize adult daycare programs, but those are there for you. You can drop your loved one there. Some of them even pick them up at 8 in the morning, and then you pick them up at 5. They have good activities. I would urge you to join a support group because it really helps to learn things from each other. And then there's the Alzheimer's Association. So last slide. Oh, I don't know what that is. Something happened. Okay. So medications, we can try, but if you're going to try them, please have a good follow-up with your physician. Understand that they have not translated into a good, meaningful change just yet. Physical exercise is strongly recommended both for prevention of dementia, but also during dementia to keep yourself healthy and as a stimulating cognitive exercise. Vitamin E is safe and there's no harm in trying it. And cognitive stimulation programs are extremely important, like doing crossword puzzles, listening to music, anything that would stimulate the brain. And with that, I'm going to end, and I look forward to the Q&A. Thank you, everyone.
Thank you, Dr. Jamshed. We appreciate your insight. You touched on so many different topics, which I appreciate. We had over 50 questions submitted in advance. Yes. While we can't get to all of them, and I really appreciate, we sent a lot of them for the audience. We sent a lot of them over to Dr. Jamshed ahead of time, so she was able to tackle quite a few, but while we can't address every single one, I'd like to just jump right in. First, we're gonna start with some questions submitted ahead of time, and then we will also address questions that have been asked in the chat. So the first one.
May I change that, Joya? Can we address the ones that are here? Quickly?
Absolutely.
Yes,
absolutely.
because
so
everybody's here, and yeah, I want to address it first.
Absolutely. First question from Janie. or Janie. I think it's Janie.
Yes, it's Janie. I had just asked, is it true that if you recognize you're losing your memory, then it's not Alzheimer's disease?
No, it's not true. I think I will tell you, it's amazing to me how people with Alzheimer's dementia, how much they have insight. And a lot of people, when they know that they're losing their memory, will try to hide and mask it because they don't want their loved ones or friends to know that. So if you're recognizing that you're losing memory, it could be two things. One is that it's normal part of aging because there is some word finding difficulty and changes with aging. Second is that you may have what we call in mild cognitive impairment, which is not a dementia, but it could be a precursor. So that's something you want to discuss with the physician.
Thank you.
Thank you. Next, I'm going to call on Barbara.
Hi, can you hear me?
Yes.
Yeah.
Hi, I was wondering if you would address the use of prazosin for either sexually inappropriate behavior or aggression. I've seen that used in lower doses, higher doses than for hypertension.
Yes, I'll be honest, I've never used it. And the big reason for not using it is the side effects.
Okay. Yeah.
Most of our people will not tolerate it, especially if they have been on other medications. The go-to drug right now is mostly, as I said, the antidepressants in lower doses, or we can use the atypical antipsychotics if such behavior is occurring. I think prazosin may be something more commonly used in frontotemporal dementia, which is a dementia of younger people that would start with disinhibition and inappropriate behavior from the get-go. It's not something that I would use in an older person.
Thank you.
Dr. Jamshed, would you mind unsharing your screen just so we can see?
Oh,
it?
yes. Yes, there you go.
So many lovely faces. Okay, we have another question from Cecilia. Cecilia, would you like to unmute yourself to ask? If not, I can ask for you. Cecilia, are you there?
Yes, I'm here.
Oh, great.
Yeah, no, my question, it was about any day activity centers that have Spanish-speaking personnel that can work, or staff that can work with my dad.
I know there are. I don't know any particular ones that I can name for you, but if you want to leave your contact with Jenny, I'd be happy to look up some and send you the information. Anyway, I'll stop there. We have a wonderful social worker who is Spanish speaking, and I can reach out to her and she can give us some names.
Thank you very much.
Mm-hmm.
Thank you. Wendy, would you like to ask your question? Wendy?
Yes, hi there. Thank you very much. I was curious if you could tell us. Hi there. I was curious if you could tell us a little bit about what might be on the horizon in terms of some of the researches going on and things that might look promising in terms of future treatments.
Yeah, I think the main research is all focused on amyloid deposition and how to reduce that. That's one. The second one is prevention in vascular components. When I was at UCLA, we were studying turmeric, and we were actually injecting them, trying to see if that might help. And unfortunately, that did not translate. And one of the reasons behind it was that it was, in India, they used turmeric in food, and they found less Alzheimer's there. But it seems like the neurotransmitter theory is not going to be the one to work for Alzheimer's, at least. It's going to be focused on how we can reduce the amyloid burden or prevent it from happening in the first place. So this new drug, the monoclonal antibody, that's where it's going to be working if it actually works. So I think that's pretty much all I know about the research. I'm not a researcher, and I don't know if there's any other research that might be going on.
Thank you. Our next question is from Shilpa, who actually submitted in advance and is here. Shilpa, would you like to unmute and ask your question? Can I give it a few moments?
Hi, I wanted to ask, are there any effective ways to slow the aging process? Like I've heard some research about resveratrol or other supplements like that.
No, unfortunately, I think the only thing we can do to, so prevention, exercise, we do know exercise reduces the risk of dementia, but we're talking about 150 minutes per week. So that's 3 times a week, right? We have tried all the supplements for prevention, and that has not worked. We've tried all these drugs that are supposed to slow down. So memantine was the first one that actually said it's what we call neuroprotective, and it's supposed to slow down the process a little bit. But unfortunately, that has not translated into real life. It translates into study research and numbers. So we're still working on that. I think that if we can figure out how to reduce the amyloid burden, not just for dementia, but lots of other diseases, that may be something that we could look into. But if I had to pick something at like now or even during dementia that I feel like would help, I would focus on exercise.
Thank you.
Thank you. LaShonda, would you like to unmute and ask your question?
Hello. My question has a lot to do with just lifestyle. So, you know, people in their 30s and 40s or even earlier, right now everyone seems so overwhelmed and, you know, we're all working so hard and we tend to be like scatterbrained. Speaking for myself, I always feel overwhelmed a lot. And I keep telling myself, I feel like this is going to drive me towards having dementia. And I'm just wondering how accurate that is, or if I'm, you know, just feeling overwhelmed.
You know, the thing about stress is that there's other thing that it leads to, right? So the cardiovascular issues related to it. And if you're not talking about Alzheimer's, there are other things that can be affected from high blood pressure, from diabetes, from, you know, stress. So I think that you're pointing it out correctly. I mean, right now I'm sitting here and I'm going somewhere tomorrow and I was working during the day. It's a lot. And somehow we have to try to take out even 30 minutes to just shut everything else down and relax. And I don't think there's any science behind it, but I think it helps. I know exercise helps. So if that's the time that you can put aside for exercise. So the best stress reliever is exercise. And the reason it is because it releases endorphin. And you get that euphoric feeling after doing it, and you're, you know, a happy person, and that helps a lot. So, but to answer your question directly, it's not going to lead to dementia. Okay, we're still trying to figure out what does that. You know, age unfortunately is one of the risk factors. The longer we live, the longer the risk that we're going to get it.
Perfect. Thank you so much.
You're welcome.
Thank you. Linda? Oh, Linda, can
Yes, well, there you go.
There you are.
Yeah, you know, I think you may have answered this, but I was curious as to, you know, what level of intensity. Is it aerobic exercise? Is it a combination of like resistance training together with aerobic exercise? Like, I don't know if there's any evidence as to the type and the duration of exercise.
There is. It's such a great question that you asked. So they actually do recommend that the exercise needs to be intense enough that it increases your heart rate to the goal. So you want to get to that 80%. For people to maintain their health and prevention and for those purposes, 150 minutes per week is enough. When people are trying to lose weight, then we tell them a lot more. But all we need to do is 150 minutes. That's 30 minutes, 5 days of the week.
But also getting our heart rate up.
Right. So again, your doctors know how to do that, and they should tell you. So a stroll down the street doesn't count, unfortunately. You have to have a fast stroll, you have to walk. And for people who can't walk well, upper body workouts. Strength workouts actually make your heart rate go up a lot. And I don't think people realize that. Now, to answer your strength answer, that's a very good exercise to prevent osteoporosis and keep fit and prevent muscle loss when we're older, which is a separate issue that has consequences. But yeah, so hopefully we can get that heart rate up, and that will be helpful.
Okay, thank you.
Thank you.
Thank you. Judy, would you like to unmute and ask your question? It's an interesting question.
Sure. Can you hear me?
Yes, we can.
Okay. So being a caregiver, I've cared for my grandmother and then now my mother at early onset. And so especially the pandemic, you're absolutely right, has nosedived. So with that being said, I did read an article on B vitamins or B complex vitamins helping, or do you know of any literature on that? And then in addition to looking at my generations, what's in store for me later, what should I be doing to help myself and my sister?
Sure. So couple of things, and I'm glad. We have some data to show that plant-based diets help, but it's a big lifestyle change. So that's one. We talked about exercise as far as prevention for you and your sister. We talked about, taking some time out for yourself. In general, vitamins help if you have a deficiency in that vitamin, right? So it's so if you have a deficiency in vitamin B12 and that's causing memory problems, then it will help. If you have a deficiency in vitamin C and that's causing problems with healing of wounds, it will help, but otherwise it doesn't. Vitamin E was studied in people who already have dementia to see if it will slow down, and the results are conflicting. So that's the only one that we know that there is some data on that. Now, does that mean you shouldn't take the vitamins? Take the vitamins, it's okay. I mean, you don't have to get tested for B12 deficiency. Taking a B complex every day, honestly, I haven't stopped people from doing that, but it's not really going to prevent a decline or dementia, but it will prevent if you have any other deficiencies or any issues related to it. So sometimes doctors will check the levels. I've done that too, only if I have a high suspicion that the person may have a deficiency in it. Otherwise, you can just take it every day. Commonly, people who have stomach problems or who've had bypass surgeries, those are the people who have the vitamin B deficiencies, or people who are dependent on alcohol. So that's where we would definitely need it. I want to tell everybody a little bit about our program because those were questions submitted. And we have only a few minutes left. And I'm, by the way, happy to answer and go on a little bit longer if needed. We have a home-based primary program. Barbara, yes, I mean gastric bypass, not the regular sleep, not the weight loss surgery. So we have a house call program that provides primary care at home. Currently, we provide care at home around our UT Southwestern campus, about 15-mile radius. The people who would truly benefit from that program are those who have multiple chronic conditions and require assistance in personal care, like bathing and dressing, and have also been hospitalized. But I will tell you that we take care of anyone who has a lot of difficulty coming to the clinic. And if they didn't get to see a doctor, they will fall through the cracks. So I have a lot of, almost half of our patients have dementia. And, some of them don't necessarily need personal care, but for the family member to bring them to the clinic would take so long just for a 30-minute clinic. We also are able to spend more time with the person at home. We see patients in assisted living, at home, in group homes, but we don't go to nursing homes because our whole philosophy is to keep people out of the nursing home. So if you want to know more about the program, Joya can put the link up. And there are other programs in the city as well that provide house calls.
Thank you. I'm going to try to take two more questions if we can. Okay. Renee asked, is there any data showing diet sodas contribute to Alzheimer's disease?
So the plant-based diet, not contributing, but preventing. There's actually some good data to show plant-based diet helps with cardiovascular, the heart mortality, disease and others. So you have to remember that Alzheimer's disease is not the only type of dementia. There are other dementias that I talked about that are not what we call neurodegenerative. And that's where diet, exercise, controlling your weight, blood pressure, things like that really will make a difference. So I've tried plant-based diet for one day, is all I lasted. It's a big lifestyle change. You really have to be committed to it. And if you can do that, then sure, just there are some things that you have to be careful about. And again, you need to talk to your physician before you're going to make a big change with your diet.
Okay, apart from a plant-based diet sodas, so like a Diet Coke, a Diet Sprite, is there any research of a correlation?
So there was some data that came out when Splenda was being used a lot as a substitute. And there was some studies that showed that there was memory problems and cognitive problems, mostly forgetfulness associated with that. And since then, everybody's been cautious. But honestly, the data is not 100%. My personal recommendation is always not use artificial stuff. Just use natural stuff and try to use less of it. I think it's okay to use sugar, but just use less of it if you can. But if you're somebody who's putting like 3 teaspoons in your coffee, then maybe a sweetener would be okay. But there's no good data to say that. So if you like your Diet Coke, I personally think it's okay to drink that.
Thank you. Kathy, would you be able to unmute and ask your question? Kathy, if you're still there. If not, I will go ahead and ask it for Kathy. Is there any link between using aluminum-based antiperspirants and development of dementia?
Not that I know of.
Thank you. And our last question, Michelle, would you like to ask?
Yes, thank you. My mom was just diagnosed with dementia and was referred to UT Southwestern Memory Clinic. My question is, with the limited amount of benefit from the medications, what exactly would the expectation for going to the memory clinic just to be evaluated? What would be expected from that?
It's actually a great question. I personally think it's important to see someone who specializes in this for a couple of reasons. Number one, it's helpful to know the type of dementia or cognitive issue that is happening, right? It's important to address anything that might be reversible. So there are things like B12 deficiency, thyroid problems that could be contributing. It's also very important to know what stage of dementia you're at, because there are interventions that we can do at different stages to improve the person's quality of life. And lastly, the 3 things I talked about, planning. So if you, at different stages of dementia, your ability to, the capacity of making decisions will change. So if you can actually assess where the stage is, then whatever decisions need to be made can be made at that point. And then you can follow up with the memory clinic maybe every other year, or have your regular primary care doctor sort of follow up the trajectory and do the assessments. So we do our own because we do it at home, but there are a lot of people who get seen at and they do a really, really good job. It's very thorough. And I really think it's going to be very helpful for you to understand what's going on. And sometimes it actually is also for people where we think that, I can do this, but I can't do that. And then you realize, well, unfortunately, you can't do both. And then if you're ever having a hard time telling your loved one about driving or not driving, that's the other place memory clinic might be able to help. I think somebody had asked a question that was submitted about the genetics. And I want to just clarify that is genetic Alzheimer's disease is very rare. It's almost like less than 1%. If somebody is worried, I would think about people who have early onset dementia, like in their 50s or 60s, and their siblings or children getting tested. It's a genetic defect that you can get tested for. But other than that, it truly is unfortunately a disease of aging. There's just a high risk of it as we get older, and a high risk in women. You don't have to be worried about having genetic predisposition if your mom had it at 80 years of age. So just wanted to clarify that. And Dr. Freeland has been very helpful. She's my colleague in the chat group, answering some of the questions. It's very hard to do research in dementia. You can't give something that's toxic, and you can't give something and then not give it to the other person. It's not that easy, but the main research is going to be at the basic science level, where the actual neurons are being damaged. And that's where the research is being done at our Alzheimer's Center and Neurology Center. I'm more clinical, so I focus a lot more on dementia set-in and prevention, but there's tons of research going on. As I mentioned early on, we have about 244 drugs tested to date, and honestly, only one of them was FDA approved for treatment of dementia, which is the newest one. Other than that, we don't have anything.
Dr. Jamshed, this has been fascinating and really remarkable. You and your colleague, Dr. Freeland, have been really insightful tonight on the science of aging. So thank you so much for your presentation and joining us tonight. Thank you to Joya for being my partner and running things this evening. And everyone, we hope that you'll join us again in 2 weeks on Thursday, December 2nd. Joya is going to put a link in the chat for the final program of our year. It's going to be focused on mental health issues in the pandemic, and especially the winter blues that sometimes really hit during the holidays. And so we hope that you'll register and join us again. For now, before we adjourn, as always, we must implore you, your friends and your family, to get a COVID vaccine, and if possible, a booster shot. And I'm going to also add your flu vaccine, your flu shot. These vaccines protect us from severe illness and death from COVID-19 and its variants. And we're seeing 100% Delta variant in all the samples that we're testing at UT Southwestern. For more information on COVID, including vaccine appointments, click on the yellow COVID information bar at utswmed.org. And even if you are vaccinated, please try to wear your masks and social distance and be vigilant with hand hygiene. And thanks for doing your part to focus on our collective public health. And as we close out, we all from UT Southwestern wish you all a happy holiday of Thanksgiving. Thank you for joining us tonight, and we are adjourned.
Thank you very much, everyone. Thank you.
And do email me if you have questions for Dr. Jamshed, and I will get them to her.
Thank you. Happy
Thank you,
Thanksgiving.
Dr. Jamshed. Yes, ma'am.